We will move on to a talk by Dr. ARUP Chakrabarti on intraocular management in presence of posterior capsular rent. Dr. Chakrabarti does not require any introduction. He is a senior consultant at Chakrabarti Eye Center, Trivandrum. He is a present editor of AIOS Proceeding and a very good human being and perfect surgeon. And we have all read the posterior capsular rent book and the very good article in IGO. He is recipient of various awards and he is a very famous faculty nationally and internationally, and his instruction courses are well attended not only in India but by American Society conferences also. And we are very happy to have Dr. Arup Chakrabarti with us for taking his talk on IOLs, how to perform. Thank you, sir. Thank you so much.
Thanks a lot, Dr. Vinita, for including me in your course and for the very kind introduction. Choice of an intraocular lens in a routine cataract surgery is a topic in itself. However, this topic becomes more important when you have an intraoperative complication like a posterior capsular rent. I'll show you a couple of cases which were referred to my practice or walked into my practice where inappropriate lenses were used, where the patient had unexpected PC rent, I assume. So here you have a single piece single piece PMMA lens flipped and kept in the anterior chamber, haptic going through the PI. This was another case where a three-piece lens, it was again implanted in the anterior chamber. And if you see these gonio photographs, these are the looped haptics. The end of the haptics have got eyelets, and it created havoc. Explanting these lenses is also going to be very, very difficult. Regarding AC lenses, here you have a situation where the surgeon has used a very big-sized anterior chamber lens, and that is again flipped. Okay. Similar situations, here again a lens, AC lens, where the trailing haptic that is still present in the section. So this actually is a good lens, but the only thing is it has not been appropriately handled. So in my presentation, I'm going to show you a few cases where PC rent was encountered during IOL implantation and how those cases were managed. Now, this was a 2.8 millimeter incision topical clear corneal approach surgery, and leading haptic is going. One sec. Yeah. So this is actually surgery has gone off extremely smoothly. There's no intraoperative complication so far. And then I am squeezing the lens. It is a sensor lens, AR40E, which goes into the anterior chamber. So the leading haptic goes in pretty smoothly so far, as you see here. And most of the lens has been delivered within the capsular bag. And it is just the trailing haptic that has to be dialed into the capsular bag. Now again I go from the one of the side ports, and as I try to dial the lens in, there's a snap. This is something which I felt, which could be palpated, and then you can also see it on the video. So it will be again shown in slow motion. So at this moment, if you see here, at this juncture, there was a snap. So I realized that because of excessive stretch on the posterior capsule, maybe it was a fragile posterior capsule, I do not know, there was a posterior capsular rent. So it is quite possible that if the PC rent enlarges, the same lens will dislocate into the posterior segment. So I am, my heart is in my mouth, and I'm just waiting to see how the eye behaves. So the OVD was removed. The lens was very well centered. It had not shown even 1 micron of decentration. And you will see at a certain point that when the lens did not decenter, and I know I had a huge PC rent. For example, here if you see the nasal side, there's no posterior capsule. So it is just a rim of posterior capsule in the periphery, which is supporting the lens in the capsular bag. See, it is very clear here. So in this situation, there's no need to tamper with the lens position. So this should be fine. So this is the postoperative period. The patient had a best corrected vision of 6/6 partial. And one thing I just wanted to bring to your notice is, though the patient was asymptomatic, but since part of the lens had PC behind it, and rest of the part, and one big chunk of the lens, posterior surface, had only the anterior vitreous face. So there is some lens tilt. So when I put the patient on the eye trace aberrometer, you see a lot of aberration coming from the entire eye. This is not from the cornea, this was internal. So basically it is the slight tilting of the lens that had given us to this situation. This is another case I wanted to show you. Phaco went off very uneventfully. It was an immature it was a total cataract. Now here was look at the leading haptic. It comes out vertically. It impinges on the posterior capsule, and I was not very maybe attentive, and I didn't realize that there's something amiss. So as I dial the trailing haptic try to dial it into the bag, see there is significant decentration of the lens into the on the nasal side, east-west decentration. So I realized that I'm dealing with a very large posterior capsular rent. So now how the rent happened, it gets clear when you see the slow motion view. Now the leading haptic comes out vertically, so that is what it should be. But too much of it comes out, it impinges on the posterior capsule at this juncture. It penetrates the posterior capsule. Then when I rotate the lens anti-clockwise, the small micro puncture gets bigger in size. And then the posterior capsule sort of rips open, and you have the lens that is going to dislocate into the posterior segment. So how do I manage this case? So first thing first, I still have a good anterior capsular axis. So I decided that I will ensure that the lens doesn't go down by externalizing the trailing haptic, and then keep the lens in the ciliary sulcus with a buttonholing of the optic. So manipulations have to be very, very gently done. You inject copious amount of a dispersive OVD viscoat behind the lens, because I don't want to be disturbing the anterior vitreous phase. In front of the lens, because a lot of manipulations will happen in the anterior chamber. So you want the corneal endothelium to be properly preserved. Your manipulations have to be very, very careful, because I'm going to use the intact axis to support the lens when we buttonhole the optic into the bag. So a bimanual technique is used very carefully, and the leading haptic which had gone into the vitreous, into the posterior segment in front of the anterior vitreous phase is brought out into the anterior chamber. So now I'll place the entire lens in the anterior chamber, and you will use a compression dialing technique where you see the haptics are not rotated, but they are compressed, and they're going to be kept in the ciliary sulcus. Before that, you have to form the ciliary sulcus by compressing the peripheral capsular bag by injecting a cohesive OVD, which can be easily removed subsequently. The same thing is done for both the haptics, and now I'm tapping the lens the optic edge sequentially to obtain the posterior buttonholing. So lens, the circular rexis has become overlaid, and this is the postoperative picture. And see, whenever we show complication, intraoperative complication, it is important to show the post-op situation. Otherwise, postoperatively, you have a lot of problems, but you give a wrong take-home message to the delegate. So whenever I show any complication, I make it a point to show the postoperative pictures. So this is a complication which could have been avoided. Never keep a single-piece hydrophobic acrylic lens in the ciliary sulcus. I'm talking about unexpected posterior capsular rent. So in a situation where you have an unexpected posterior capsular rent, and you don't have a scleral fixation machine equipment, lens, and the gadgets available with you. So I'll go for an anterior chamber lens if there is no contraindication. These lenses do extremely well. Only thing is they have to be handled properly. You have to do a good anterior segment toilet, remove all the vitreous from the anterior chamber, and then implant the lens. So now this is the common mistake that happens. The lens has to be vaulted anteriorly when it goes into the eye. Many a situation I have seen in live surgery situations where experienced surgeons have flipped the lens, so the lens is vaulted posteriorly, scraping the iris tissue, and then postoperatively you can expect UGH syndrome in these patients. So this is the way you have to handle these lenses, and this was again I converted intraoperatively. So initially I started a phaco, and there is an issue, intraoperative complication, so I decided to go for an AC lens. I could not take up the patient second time because of medical reasons, and otherwise I would have done a scleral fixation on a second sitting, not on this sitting, because as we mentioned, the eye is very soft, and it is not right to perform surgery in such a when we have encountered a complication. So it is an AC lens which is being handled properly. It is kept horizontally. A peripheral areotomy will be performed, and this patient would do fine. So this is the end of my presentation. Thank you very much for your kind attention.
Thank you so much for your excellent videos as usual, and very good teaching. But if there is no ACIOL also, sir, what to do?
Yeah, I think, At the time of counseling itself, it has to be very clearly told to the patient that some part of the surgery may require second stage procedure. For example, if you have a drop nucleus and you do not have the posterior segment surgeon available, so the patient should know that the rest of the surgery may have to be completed in the second sitting. And certain situations where you don't have the appropriate intraocular lens, you can always render the patient aphakic. So this discussion should not take place on the operating table. It shouldn't take place in post-operative period. It should be done as the counselor counsels the patient in the preoperative period. Each and every patient that we operate is informed about the possibility of keeping the patient aphakic and performing a secondary procedure at a subsequent time.
Thank you, sir. Thank you. Any comments?
Sir, what medicines do you prescribe after this type of procedures? Like, do you add any NSAIDs, or you only give the and the cycloplegics with the steroids?
For ACL patients?
And with any of this complete, suppose
No, see, my routine strategy is to use an NSAID for 6 weeks. Whenever there has been a PC dent, we followed up the patient properly, because periphery has to be seen. So maybe instead of 6 weeks, the patient will get NSAIDs for maybe 8 weeks or 12 weeks.
also
But this has to be.
no role of oral antibiotics, because I have seen few people giving, but I don't give. Do you give, sir?
Antibiotic for what?
Oral antibiotic.
No. See, another thing I wanted to mention. This was not a talk on PC dent, so I didn't touch that point. I do not use a prophylactic intracameral moxifloxacin for any of my patients, unless I have a PC dent situation. In that situation, this is the only situation in my practice where I use intracameral moxifloxacin, because their studies have shown that the incidence of post-op endophthalmitis can be 9 to 10 times more if you have a PC dent with or without vitreous disturbance, but not systemically.
Thank you, sir.